Assalamualaikum and good afternoon, everyone. I'm Ahmad from one of the urologists from UC Malaysia. So I don't remember arguing that much with Mr. Arun, but maybe it's good that I can't remember. But anyway, so I'm going to go through, we got three parts because we're going to talk about the assessment of erectile dysfunction. So we got the clinical assessment, the cardiological assessment later by Dr. Adam, and also got the psychological assessment by Associate Prof. Nadzirah later. So next, without further ado, let's proceed. Okay, so the learning objectives: to know the steps to be taken in history and physical examination for accurate diagnosis of patients suspected of having erectile dysfunction. I mean, basically, this is the first encounter with the patient, erectile dysfunction. So, okay, so as we all know, one nice thing about most guidelines and CPG, we have the algorithm. So this is the first algorithm in our CPG. So patients present and normally goes as with any patient encounter, starts with history taking, preferred partner, physical examination, assessment using tools like IAF, and then if necessary, further investigation. So the encounter has three aims. Of course, number one, I mean, it's a ED talk. So the main thing is to diagnose and classify erectile dysfunction. And as what Dr. Adam has elucidated to, there are quite a few potential reversible risk factors. And so this is one thing we definitely want to look at. But the other thing also is there's a strong association, as later my colleague will go into more detail. There's a strong association between cardiovascular disease and erectile dysfunction. So it may be the first time that we actually find someone who's at risk of maybe getting an MI within the next week. And the other thing, also to find and diagnose psychological illness, whether they are the cause or then they're the sequelae of erectile dysfunction. So history taking, we start with assessment, should begin with a detailed medical, which is your standard HOPC, past medical history, whatnot, but also need to take an in-depth sexual history and psychological history. And where it's possible, it's always best to put with the partners. But I won't put partners there just in case there are more than one. And the history should include information about past and current sexual relationships, previous consultations, and treatments, which may not necessarily just be standard, can also be traditional treatment. Okay, so history presenting complaint, you ask about on duration, onset, but other important things will be asked about libido and also certain details about the sexual encounter lah. So that's one thing that sometimes it can be a bit uncomfortable, not just for the patient but also for the primary care physician. So it's important to do in a nice, quiet and comfortable setting. Okay, other things, standard past medical history, mainly of course about sexual dysfunction, but you notice that a lot of it is about things that predispose to cardiovascular disease, and of course any previous surgery, particularly in the pelvis, is important as well. A lot of medications, as again mentioned by Dr. Adam earlier, can predispose to erectile dysfunction, and it's also important to know medications which may actually prevent us from giving certain treatment for erectile dysfunction. Psychiatry, I'll leave it to Prof later, but other things, social history, smoking, alcohol consumption, illicit drug use, the Mediterranean diet that has been mentioned a few times, and also exercise, and also need to know a bit about the culture and religious aspects. Sexual history, okay, uh, quite important, not just about how many partner, the age of the partner, expectation of the partner, sexual orientation, because we also, not all maybe we have to also respect if the orientation is a bit different. And of course, particularly in certain cases, particularly those with spinal cord injury, some may actually be seeking to get children. Okay, one important thing to help differentiate between in the history is to try to diagnose whether this could be organic, psychogenic erectile dysfunction. So generally for psychogenic ED, the onset tends to be more acute and it tends to be situational. No, you just lost your job, so suddenly the erectile dysfunction appeared, and it tends to come and go, intermittent. So for example, it's okay on holidays, but it's not good when you're working. And the other thing is that things like morning erection and non-coital erection are normally of no problem. But so organic tends to be a more gradual cause, and one key feature is usually the early morning erection is not present. That's how to differentiate. So things that we can use to help history taking, one of them is of course the IAEF 5, because we don't normally use the full IAF because it's a bit too long to do, particularly in the busy GP clinic. And so this is what we use most of the time, and ideally it should be filled up by the patient, not by us. And other thing you can use as a marker of how hard the erection is the erectile hardness score. Okay, and don't forget, what although not really covered because of time constraint in the CPG, need to screen for potential hypogonadism as well. Okay, so this is the English version of the AF. So it's a five instrument questionnaire, and the score is from uh, basically from from 5 to 25, with the maximum score 25 means has no erectile dysfunction, because 5 will be severe erectile dysfunction. Okay, and there's a lot of version in different languages, including Malay, Chinese, and even Tamil. Okay, this is the erection hardness score. So normally it's a numerical score. Based on 4 is very hard, 0 it does not enlarge, but sometimes people like to compare it to certain instruments in the kitchen. Okay, physical examination, everyone as per any consultation need to undergo physical examination, but not just abdomen, but also considering endocrine, vascular, and if relevant, urological examination. BMI is important, as mentioned Dr. Adam earlier, because of the risk of obesity, not just for ED, but also risk for cardiovascular disease. And genital examination is important because certain things like Peyronie's disease, signs of previous STDs, all may actually give a clue to why they might be having erectile dysfunction. Investigations, generally the one that we do is for all ED will be checking for diabetes and lipid profile. Again, part of a CV risk assessment. Other lab tests depends on the patient. So if you're thinking about hypogonadism, then you may do testosterone, prolactin, and LH hormone. Whereas if you're thinking there is a possibility of prostate cancer, then you may think about doing a PSA. Okay. Advanced workup not frequently done, but one thing we can use is this one is a nocturnal penile tumescence recording. So basically you strap a device to your penis, sleep, and then it tells you whether there was erection or not. Okay. And if you have an erectile event lasting more than 10 minutes or at least 60%, then it suggests that your erection process is normal. So the idea is that you can help to differentiate whether this is organic or psychogenic. But the thing is that, if you have sometimes you may not necessarily have a nocturnal erection, depending on your dream, depending on your stress or not. So it's not really, 100% differential thing. Okay. Other thing is certain thing we may do a duplex ultrasound, but before you do the duplex ultrasound, you actually need to inject uh, alprostadil first. So that's why it makes it not very popular. But it can help confirm the potentially vasculogenic ED. Those are some markers what we consider as normal, but again, these are not exactly fixed in stone. Okay, angiography may be reserved if you're planning for penile revascularization surgery. Okay, but otherwise we don't routinely do this. Okay, and as mentioned, this advanced test is not what we do routinely. Mainly what we do is the history, physical examination, IAF, plus minus EHS, and W investigations. But you have someone with ED of which you don't know what's the cause, very young patient where you think they may need penile revascularization surgery, those with penile deformity, those you're thinking have endocrine problem, and the other thing that may necessitate this kind of investigation is where there's a medical legal case where they want to prove erectile dysfunction for claim purposes. Okay. So take home message, a comprehensive medical, psychosocial, and sexual history should be taken in every patient. Validated questionnaires we can use, such as the IAF and plus minus EHS. Examination should be done, not just for the genital urinary system, but also to find other underlying medical conditions. Routine lab tests mainly for elucidating cardiovascular risk, and specific diagnostic tests only when it's indicated. For cardiac risk, I'll pass to the next speaker. Thank you.